You know, that split second losing your balance. We've all felt that. And that instinct, throwing your hands
Yeah.
out.
Pure reflex, isn't it?
Totally. But unfortunately, that reflex can be exactly what leads to an upper limb fracture. So for this deep dive, we're really focusing in on these injuries.
Right. Breaks, cracks from the shoulder down, basically.
Exactly. And we want to make this super clear and efficient for anyone needing to revise this stuff.
Yeah, upper limb fractures, you'll definitely see them. So having a good handle on the different types is, well, it's key. Whether this is revision or brand new info, we're aiming for that high-yield overview.
We've got some solid notes to guide us.
We do.
Because, let's be honest, the number of different fractures can feel a bit much. Wrist, forearm, elbow.
It can seem like a lot at first glance.
But we're going to break it down. Focus on the really crucial bits you need to know. Think of this as your fast track for upper limb fractures. Okay, ready to dive in. Let's start with a real classic, Colles fracture.
Okay, Colles. So this is a transverse break across the radius, one of your forearm bones.
Yeah.
And it happens usually about an inch, maybe slightly more proximal to the wrist joint.
Right, near the wrist.
Yeah. And the key thing is the displacement. The broken bit of the radius shifts backwards, dorsally, and angles up. This gives it that classic look.
The dinner fork deformity?
Exactly. The dinner fork. You can sort of picture a fork tine bent backwards.
Yeah, you really can. And the cause, the etiology, you mentioned it falling onto extended, outstretched hands.
That's the one. That reflex we talked about. It just sets you up for it sometimes.
Makes sense why it's so common then. Okay, to help remember the key bits, how about that mnemonic idea? DDR 1 inch.
Yeah, that's good. Let's break it down.
So D for dorsal displacement.
Right.
Another D for dinner fork deformity.
Uh-huh.
R for radius transverse fracture.
Yep.
And 1 inch for being roughly 1 inch proximal to the joint.
That covers it perfectly. DDR 1 inch.
Nice, nice.
And clinically, that dinner fork shape is often quite visible.
So what's the usual approach? How's it managed?
Well, often it's closed reduction. Basically, manipulating the bones back into place without surgery. Then a cast.
Okay.
Prognosis is generally pretty good if it's managed well, though some people might get a bit of lasting stiffness in the wrist, you know.
Right. Okay, so that's Colles'. Now, what about its counterpart, Smith's fracture?
Smith's, the reverse Colles, as it's often called.
Reverse, so opposite displacement.
Exactly. Instead of that backward dorsal angulation like in Colles', here the distal fragment, the broken end of the radius, angles forwards towards the palm side. Volar angulation.
And that gives a different look, right? Not a dinner fork.
No, this one's sometimes called a garden spade deformity. Imagine this sort of flat angle of a spade.
Okay, garden spade. Got it. And the fall is different, too.
Yeah, kind of reverse as well, typically falling backwards onto the palm of an outstretched hand, or maybe falling with your wrists bent forwards, flexed.
So fall backwards or wrists flexed. Garden spade. Fall forwards, dinner fork.
That's the gist. The key is that volar or palmar angulation for Smith.
Okay, clear difference. Right, let's move up slightly towards the thumb base. Bennett's fracture sounds quite specific.
It is very specific. Bennett's is an intra-articular fracture. That means it goes into the joint surface.
Okay, involves the joint.
Right, at the base of the thumb metacarpal, where the thumb joins the hand, essentially.
And how does that usually happen?
The typical cause is an impact along the length of the thumb, an axial load, when the thumb metacarpal is slightly bent or flexed. Often seen, interestingly, after fistfights.
Ouch. Okay, not just a simple fall then. What's the giveaway on an X-ray?
You'll typically see a small triangular fragment of bone broken off at the base of the metacarpal, specifically on the ulnar side. Because it's intra-articular, getting it lined up right is really important for future thumb function.
So management might involve surgery more often?
Often, yes. Pinning or other fixation methods are common to hold that fragment in place while it heals.
Right, that joint involvement is key. Okay, let's shift focus now to the forearm. Monteggia's fracture. Distinctive name.
It is, and it's a combination injury. Monteggia's is defined by a dislocation of the proximal radial malar joint. That's the joint between the radius and ulna near the elbow.
Okay, up near the elbow.
And it happens along with the fracture of the ulna shaft. So broken ulna, dislocated radial head at the elbow.
Got it. 2 parts. What kind of fall causes that?
Usually a fall onto an outstretched hand, but with the forearm forced into pronation, palm facing down.
Okay.
And it's really, really important to pick this one up quickly. Missing it can lead to quite significant long-term problems with elbow and forearm movement.
So early diagnosis is critical. Needs surgery usually.
Typically requires surgery, yes,
Mhm.
to fix the ulnar fracture and reduce or put back the dislocated radial head.
Okay, definitely want to be aware of. Now, sticking with the forearm, Galeazzi fracture, is this kind of the opposite of Monteggia? I think the notes mentioned comparing them.
That's a good way to think about it, actually. A Galeazzi fracture involves a break in the radial shaft.
Okay, the other bone.
But this time, it's associated with a dislocation of the distal radial nerve joint, so down near the wrist.
Ah, okay. So Monteggia ulnar fracture plus proximal elbow dislocation. Galeazzi radius fracture plus distal wrist dislocation.
Precisely. That visual comparison, like from MedComic,
Yeah.
really helps lock that difference in. Monteggia up top, Galeazzi down below, essentially.
That's helpful. And the mechanism for Galeazzi.
Also, often a fall into the hand, but usually involving a rotational force through the forearm.
What might you see clinically?
Well, bruising, swelling, tenderness, usually over the lower part of the forearm. And sometimes you might notice that the end of the ulnar head, is quite prominent at the wrist because that distal joint is out of place.
An X-ray confirms the radius break and the dislocation at the wrist end.
Right.
Moving back towards the wrist again. Barton's fracture. This sounds like it might build on Colles or Smith's.
You're right, it's related. A Barton's fracture is a fracture of the distal radius, and it can look like a Colles or a Smith's pattern.
Okay.
But the key difference is that there's also an associated dislocation or subluxation, a partial dislocation, of the radiocarpal joint. The main wrist joint itself is involved.
Wow, so the break and the whole wrist joint is unstable. That sounds like a more significant injury.
It generally is, yeah. The mechanism is typically a fall onto an extended wrist that's also pronated, palm down. That combination of forces likely causes both the fracture and pushes the carpal bones out of place relative to the radius.
Right, higher energy maybe. Okay, now onto the carpal bones themselves. Scaphoid fractures. Notes say these are the most common carpal fractures.
They are indeed. The scaphoid is that small, sort of cashew-shaped bone in the wrist, located in the anatomical snuff box.
Ah, yes, that little dip at the base of the thumb on the back of the hand.
That's the spot. And yes, the most common cause, again, is a fall onto an outstretched hand. The fracture can occur at different points along the bone, the tubercle, the waist, or the proximal part.
And the notes really stress something about the blood supply being tricky here.
Hugely important point. The scaphoid has quite a tenuous blood supply. It mostly enters from the distal end and flows backwards, proximally. So if you fracture the waist or the proximal part,
You can cut off the blood supply to the proximal fragment.
exactly, which puts it at high risk for a vascular necrosis, or AVN. The bone tissue can die off. Also, non-union, where the fracture just doesn't heal properly, is a concern.
Okay, that sounds serious. So what are the absolute key signs if you suspect a scaphoid fracture?
Clinically, the big one is tenderness, right in that anatomical snuff box. Swelling there too. Patients often have pain with wrist movements, especially ulnar deviation, and crucially a pain when you press along the line of the thumb towards the wrist that's longitudinal compression.
Snuff box tenderness, he feels red flag.
Definitely. And even if x-rays initially look normal, if you have that clinical suspicion, you need to treat it as a fracture, often with immobilization in a thumb spica cast, and repeat imaging later or get further scans like an MRI.
And the notes mentioned a specific X-ray view. Standard ones might miss it.
That's right. An ulnar deviation AP view is often needed. Tilting the wrist sideways like that helps stretch out the scaphoid and potentially reveal a subtle fracture line. That radiopedia link is great for seeing images of this.
Got it. So scaphoid. Fouche, snuff box, tenderness critical, tricky blood supply, special X-rays often needed. Okay, last one on our list. Radial head fractures. Common in younger adults, the notes say.
Yes, quite common, particularly in young, active people. The radial head is the top part of the radius, near the elbow joint.
And the cause is, let me guess, a fall on an outstretched hand.
You got it. Fouche again. The force travels up the forearm, and the radial head gets jammed against the humerus, the upper arm bone, at the elbow.
Makes sense. What would point towards this specifically on examination?
You'd find marked tenderness right over the radial head itself, on the outer side of the elbow. Movement of the elbow will be painful and limited. And a really key sign is sharp pain on the lateral side of the elbow at the very end, ranges of forearm rotation, twisting the palm up, supination, and twisting it down, pronation.
Ah, so that pain with the final bit of forearm twisting is a big clue.
It really is.
Wow. Okay. We've covered quite a bit of ground there. Colles, Smiths, Bennett's, Monteggia, Galeazzi, Barton's, Scaphoid, and radial head fractures.
We certainly have. We've looked at the definitions, how they happen, those key features to look out for, and touched a bit on management and potential issues.
And hopefully, things like the DDR 1-inch mnemonic for Colles and focusing on those specific signs like snuffbox tenderness for scaphoid or that rotational pain for radial head fractures will help you, our listener, keep them straight. Feel free to jump back if you need a refresher on any specific one.
Absolutely. And it's interesting, isn't it? As you go through them, you really start to see how the mechanism of the fall, the specific forces involved, often give you a strong clue about which fracture pattern you might be dealing with.
That's a great final thought. Understanding the biomechanics, the why, really does help solidify the what. It's not just random. There's a logic to how these breaks occur.
Definitely.
Well, for more detailed revision and practice questions on all of this, don't forget to check out pastthemsra.com and also freemsra.com.
Great resources to consolidate everything we've run through in this deep dive.